Thank you to Dr. Hung and Dr. Shaw for the invitation. Dr. Kahn and I are excited to be here as part of the Women's Health Conference. I'm Marcy Levine. I'm a primary care doctor in Stanford's Division of Primary Care. Introducing my colleague, Dr. Kahn, who's part of the Stanford Division of Obstetrics and Gynecology. I have no disclosures.
And I serve on the executive board of the American Society for Colposcopy and Cervical Pathology, which will be mentioning one of their products in this lecture.
So our objectives for the talk are to review the current guidelines for screening of cervical cancer, to discuss screening in special populations, including immunocompromised women, people living with HIV, patients who have never been sexually active, and reviewing the updated clinical management guidelines and application for clinical decision-making for people with abnormal screening tests. So certainly, cervical cancer screening is a very common thing that we do in primary care, and it's gotten quite confusing. And could certainly love some guidance on how to manage this. So just start with one of my patients that I saw this week, Monica. She's a 32-year-old cisgender woman who comes in for routine screening. Her last cervical screening was 3 years ago, and she wonders about guidelines for screening for someone her age. So wondering, where we start.
Okay, great question. We really appreciate the primary care doctors doing all this screening for cervical cancer, but it is very confusing. There's several guidelines out there and they do change every few years. So I just wanted to review what the current guidelines are. The U.S. Preventive Services Task Force released guidelines in 2018, and they're currently working on updating those guidelines, but I'll show you what the current guidelines are. And the most recent guideline is from the American Cancer Society, which released new guidelines in 2020. So here's an overview of the screening guidelines. We have the U.S. Preventive Services Task Force, and the American College of OBGYN also puts out their own guidance, which coincide with the U.S. Preventive Services Task Force guidelines in terms of what they're recommending. They do recommend to start screening at age 21, and how to do that screening depends on the age group. So for any age group, you can do cytology alone, which we typically call a pap smear, cervical cytology, every 3 years. When you add an HPV test, which is a test for human papillomavirus, the cause of cervical cancer, then you can extend the interval to every 5 years. And you can do that HPV testing either with the PAP, with the cytology, which is this cytology plus HPV testing group, also known as co-testing, or you can do HPV testing by itself. And if you choose either of those strategies that uses an HPV test, it's every 5 years that you would recommend screening. What they recommend in terms of when to start doing that testing for HPV is to start at age 30. And so in the ages prior to 30, ages 21 to 29, they're recommending doing the cytology alone every 3 years. And then starting at age 30, you can incorporate the HPV test either as a co-test with cytology and HPV every 5 years, or with the HPV testing alone every 5 years. And then at age 65, you would have the possibility of stopping screening if the patient meets sufficient cessation criteria, which are listed here. They would need to have 3 consecutive negative pap tests or 2 negative co-tests or HPV tests in the last 10 years, and no history of cervical precancer or cancer in the prior 25 years. So that's the ACOG and U.S. Preventive Services Task Force guideline. The American Cancer Society guideline differs slightly in that they say to start screening at age 25. They say not to screen before that age. And what type of screening you do, there's a preferred method of HPV testing by itself every 5 years. If you can't do HPV testing by itself, then it's acceptable to do the cytology alone every 3, or the co-testing, which is the cytology with HPV every 5. So that's an overview of the guidelines. And for your 32-year-old patient, she would fall into this category of either HPV testing alone every 5 years or a cytology plus an HPV test every 5 years.
Really helpful. It just seems sort of confusing. Is there any way that in the middle of a busy clinic that I can remember this in an easier way?
Definitely. So when we're in the middle of practice, it's hard to just go look up guidelines. And there is an app that is helpful for both looking up the guidelines as well as how to manage any abnormal results. And we're going to show you in this talk how to do that, to learn how to use this clinical decision-making tool a little bit more easily. This is the website where you can access these guidelines, and it can the app for the guidelines, and it can be downloaded to your smartphone as an app, or you can use the free web application, which is down in the right hand corner here. There is a quick start guide that is helpful to take you through the different functions of the app and how to use it properly. And then there's also a guide that can walk you through with cases. And we'll be showing you a few cases in this talk to help you understand how to input the data into the app to get your clinical decision and know how to manage your patient. This is the quick start guide. It's about 7 minutes long. It's definitely helpful for someone who just got the app and never used it before to learn how to use it more easily. And this is what it looks like on the iPhone. There are different tabs at the top that you'll notice. This is the management tab is what it's used the most for, but next to that on the left side is the screening tab. And that's where you can click into those guidelines that I just went over. The U.S. Preventive Services Task Force guideline, if you click on that, it'll bring up the website, which will tell you what to screen and how to screen for which ages.
So that's great. So I guess seeing that she is now 30, she would, based on the guidelines, either have a PAP plus the HPV, or we could just do the PAP every 3 years. When I'm seeing her, I talk with her, we do the PAP and HPV. They come back normal. How do I figure out what next to do?
So that's where you would go to the management tab on this app, and you would input her results and any prior information that you have, and then it would tell you when to see her again. So you're clicking on the routine screening, which is what she just had, and then you're inputting that she had a normal cytology and a negative high-risk HPV test. And we don't actually have the copy of the prior screening results to verify them, so we're not entering them there. And then we're hitting next to get our recommendation, which is 5-year follow-up. And that's generally the case in people who've had all normal screens in the past, and they're doing HPV-based screening.
Great, thank you. So she's heard about the primary HPV screening alone. So I'm wondering if you could tell us more about that.
Definitely. So primary HPV screening is when you use the HPV test by itself as the primary test. So you're not doing the pap smear off the bat. However, if the HPV test is positive, then you want to follow up with a triage test, and cytology could be one of those triage tests. The reason that the field is moving towards primary HPV screening is because the presence of high-risk HPV is what is truly that risk for cervical cancer or developing cervical precancer or cancer. And historically, we did screening with pap smear for many decades in the past. But we're really moving across the world towards this primary HPV screening. At this time in the United States, there's only 2 tests that are approved for FDA approved for primary screening.
And do we have that available at Stanford now?
At Stanford, we have a test that's currently approved for the cytology alone testing every 3 years or the co-testing every 5 years. That test has submitted to the FDA for approval, but it's in process. And so given that we don't have a test that's FDA approved for primary screening at this time, we're tending to follow the US Preventive Services Task Force guidelines, which are for the cytology alone every 3 years, or the cytology and HPV co-testing every 5 years. And so we're tending to do the co-testing starting at age 30 for ages 30 to 65, and for ages 21 to 29 doing the cytology alone every 3 years.
At some point, do you think we will get the HPV testing modality?
I do, and I think that because the test that we currently have is going for FDA approval, eventually that they will likely get that, or we could potentially switch to a different test system in the future.
Great, thank you. And then she's had the HPV vaccine. Does that change guidelines at all?
Another great question. Yes, we still want to screen after HPV vaccination. It does lower risk substantially for developing cancer. However, we expect that it will take decades to see this decrease in cancers. And the reason is most people are acquiring HPV in their late teens, early 20s, and it takes about 10 years for precancer to develop and another up to 10 years for cancer to develop. And so it's a long process from acquisition of HPV to the development of cancer. And so at this time, we're not recommending any changes if someone's been vaccinated. We still recommend screening at the intervals that we discussed in the prior slide. We know that the current vaccine protects against high-risk HPV types that cause 90% of cervical cancers. The previous iteration of the vaccine, which was the 4-valent, we currently have the 9-valent, protected against the types that cause approximately 70% of cervical cancers.
Great, great. That's great, thank you. And I just wanted to talk to you about another patient who is a renal transplant patient, and just wondering if the guidelines are different, the recommendations for screening are different in patients who have had transplants or on immunosuppressives.
That question comes up a lot, and we're seeing more and more patients on these immunosuppressive medications. So it's a very pertinent question. There are some guidelines for cervical cancer screening in immunosuppressed women without HIV infection. These were published in 2019, and the group is in the process of updating them. So likely in the next year or two, we'll get an updated version. But they reviewed the data on immunosuppressed people and the risk of cervical cancer. And you can actually find the recommendations in that app under this tab, the Immunosuppressed tab. If you click on that, this is what shows up for the recommendations. And they are based on the recommendations from the CDC for women living with HIV. So they're recommending in immunosuppressed females who are at higher risk to follow those same guidelines for people living with HIV.
So yeah, so it sounds like these are similar for both the immunosuppressed women as well as those with HIV.
That's correct. And I can go a little bit into more detail about it. The screening recommendations for people living with HIV. We do want to remember that the goal of screening is to reduce morbidity and mortality from cervical cancer, and that the precancer is a risk marker, not an endpoint. But we're trying to detect that to treat it and prevent it from progressing to cancer. The guidelines in people living with HIV are more intense or more frequent than in people who do not have HIV. But we also have to keep in mind that immunosuppressed populations and people with HIV have impairments in cell-mediated immunity that really helps to control HPV. And so completely eradicating it is often infeasible in these populations. And it's important to keep that in mind in the counseling, that it's almost like a chronic illness that we'll just keep an eye on and make sure that nothing is getting worse. And so the recommendation in people who living with HIV who are less than 30 is to use a pap test or cytology as the primary screening modality. And the screening age would depend on onset of sexual activity, which we used to do for everyone, but now we're saying start at 21 or 25 for everyone. But for people living with HIV, we say start within a year of the onset of sexual activity, but no later than age 21. And then you wanted to do cervical cytology at the initial diagnosis, and you're doing it yearly for the first 3 years. And if then you have 3 negative tests, then you can go to the every 3 years, which is what the general population of people who are not immunosuppressed are doing every 3 years. They're not recommending co-testing in people less than 30 because the HPV prevalence is so high in that population. And then the guidelines for when you should refer them to colposcopy have a little bit lower threshold to refer to colposcopy. So anything ASCCS or greater goes to colposcopy. If you have an HPV test with ASCCS, that can help to triage whether they go to colposcopy versus just repeating in 6 to 12 months. And then for people living with HIV who are 30 years or older, you can do either the PAP alone or the co-testing, the PAP with the HPV. Either of those strategies is fine. If you do the PAP by itself, then you're going to do that time of initial diagnosis and 3 annual tests. And then if they're all negative, from there you can go to every 3 years. If you're doing co-testing with HPV, then if it's negative at the first screen, then you can wait 3 years for the next screen. And at that time, do every 3 years. And then if there are abnormalities, then you would refer to colposcopy.
Very interesting. And so what, any other considerations in people living with HIV?
Definitely for people that have uncontrolled HIV or are very immunosuppressed, their CD4 count is less than 20, or they have multiple opportunistic infections and just have shorter life expectancy, then you don't really want to do the screening in this person, especially if they have multiple negative prior screens, because it's likely to be abnormal and it'll lead to a lot of interventions. For people with good life expectancy, then definitely you want to continue screening. And then you would stop screening when their life expectancy is expected to be shorter, and the benefit of screening just wouldn't make sense anymore. But in general, in people living with HIV or immunosuppression, you would continue after age 65 if they're healthy, because they do have ongoing cancer risk. For people who've had a hysterectomy, the screening for vaginal cancer is not recommended because the prevalence is so low. And so if they've never had any abnormals and they've had a hysterectomy, you do not need to continue screening. But if their hysterectomy was because of cervical dysplasia, then you would continue screening them after hysterectomy.
And I assume these guidelines are the same for people without HIV, for the general population, in terms of the hysterectomy and after age 65.
That is true. That after hysterectomy, we don't screen for vaginal cancer. But if they have a history of CIN2+, then we would continue screening after hysterectomy. And it is acceptable to continue screening beyond age 65 in a non-immunosuppressed population if the patient prefers to do that. It's somewhat controversial of whether we should extend the screening age, because a significant proportion of cancers are diagnosed after age 65. And so if the patient has good life expectancy and wants to continue screening, that's acceptable after shared clinical decision-making.
Great, thanks. So there's a lot of women who have abnormal PAPs that we just don't know what to do with. So for example, my patient Laura, who I just did the PAP and the HPV, and her cytology showed LSIL. She had a high risk HPV. negative cytology and HPV 5 years ago, but now I have this abnormal PAP and I'm just not sure what to do. Do I repeat it in 5 years? Do I repeat it in 3 years? Do I repeat it in 1 year? Do I just send everybody to you for colposcopy? Just not sure what to do.
Let's walk through that because it's a very common scenario. I'm going to show you how to input the data that you have to get the result that you need and to easily find that results that you can give to the patient. So when we go to the management tab on the app, we're going to input the patient's age and the clinical situation, which is routine screening in the past 5 years. And so this patient currently has an abnormal test, which is a positive high-risk HPV and low-grade squamous intraepithelial lesion, or LSIL, on the cytology. We do have prior screening results, and so we will input those, which were negative high-risk HPV and normal cytology. And that's all the information we have, so we put that in. If you had a third one, you could enter that. And then we'll go to the next screen, which shows us what we inputted to verify that that's what we meant to put in for the patient's results. And then we'll go to what the recommendation is, which is for 1-year follow-up. And the reason for the 1-year follow-up is based on the 5-year risk of CIN3+, which is cervical precancer or cancer. The 5-year risk of that developing is 3.78%. Which puts this patient in a risk category that would recommend 1 year. So she should come back in 1 year for another pap smear with HPV testing. And you'll see here it says HPV-based screening at that follow-up visit.
Really interesting. So where'd all the data for the risk score come from?
That was developed based on data from 1 to 2 million patients that were screened and followed over the course of 15 years. And this was at Kaiser Permanente, Northern California, along with some other cohorts across the country. And they were able to generate these clinical action thresholds, which are used to determine what the next step is. So it's more a type of precision management based on their actual risk threshold. And these top risks are ones that we as gynecologists are managing patients that get referred to us either for colposcopy or their risk is high enough that we can do immediate treatment on them. I would say that our primary care colleagues are managing patients with these lower risks, and they're seeing patients that are coming back for surveillance testing after they've had, for example, a colposcopy in the past, or they've had no history of abnormals. And so they're just doing their routine screening and then they get an abnormal result. And when should they see them again? And whether they come back in 1 year, 3 years, or 5 years depends on what that 5-year CIN3+ risk is. And so you'll remember for this patient, her 5-year CIN3+ risk was over 3%. And so she's in that return in 1 year bucket. And that's the reason that recommendation pops up as 1 year.
Very interesting. And then questions about women who've had colposcopy. So I have another patient here who had colposcopy a year ago that showed LSIL and CIN1. Her ECC was negative. That was done based off of a LSIL cytology with high risk HPV. I've repeated the PAP now after the colposcopy, and she still has the ASCCP and HPV positive. So now again, I'm sort of stuck what to do after this, after having had the colposcopy. So again, do I repeat it in 5 years, 3 years? Do I send her back to you guys for a colposcopy? This is now quite complicated for me.
It absolutely is. And this is one big change with the 2019 management guidelines from previously. In the past, we referred everyone that had ASCCP, HPV positive, or LSIL to colposcopy, regardless of their prior history. But what changed is that we're incorporating their prior history and generating that risk threshold, that what their exact risk is, and then we're putting them into one of those buckets to determine when we should see them again. So here's an example of that patient you just mentioned. She's 32 years old. She had a colposcopy last year. So we're actually using a different clinical situation in the app for this patient, which is management of results during post-colposcopy surveillance within the last 7 years. And we're putting in her current test, which is ASCCP cytology and high-risk HPV positive. And then we're entering what that was her first surveillance test after the colposcopy. And then we're entering what the colposcopy showed, and on biopsy, she had low grade or CIN1. And then the test that prompted the colposcopy was also LSIL low grade last year. So we're entering all of this data and then just confirming this is her current result. This is what it showed last year on colposcopy. This was her test that preceded the colposcopy. And then we're generating that recommendation for when to see her again. And in the past, someone like this would have gone immediately back to colposcopy, but you can see that her 5-year risk of CIN3 plus is 6%, and it's under 9%. So in that case, she does not need another colposcopy right away. In essence, that colposcopy not showing precancer lowered her risk for this year, and it allows her to just come back in a year to repeat the PAP and HPV test.
Help us understand, what to do when, and really put some understanding into why the recommendations are, what they are, which is really, really helpful.
And also decreases referrals to colposcopy. That's one nice thing about the newer guidelines. We're sending less people to colpo than in the past.
Women certainly appreciate that. So what about women who've not been sexually active? What are the screening recommendations for those women?
Yeah, that's a great question, and this comes up a lot too. For people who say that, I would recommend taking a really careful sexual history. And the reason for that is because a lot of people consider sexually active to be penile vaginal intercourse, but there are lots of different types of sex and sexual contact. And HPV is sexually transmitted, but this can be any form of sexual or intimate contact. It can be by touching, by oral sex, by genital to genital touching. And so I think that most people don't think about those things as sex per se, and may say they've never been sexually active, but in actuality, they probably have had some kind of sexual contact. So I would say if the patient truly has never had any kind of sexual contact, their risk is very low and it would be acceptable to forego screening. But I would say that would be a very small minority of people, that most people would have had some form of sexual contact, even if not what they consider to be, penile vaginal intercourse.
Okay. And then what about women who have sex with women?
This comes up a lot too, and there's a big misconception that women who have sex with women are not at risk for cervical cancer, and they actually have lower screening rates because of that. They're still at risk. Like we said, HPV can be transmitted by a skin-to-skin contact with the genitals, by oral sex, by vulva-to-vulva sex. And so it's important that women who have sex with women with a cervix be screened for cervical cancer per the national guidelines, the same as anyone else. And we just published this paper last week. It came out about organ-based screening recommendations for HPV-related cancers. And we review the data on HPV in sexual and gender minority populations and make recommendations for screening. And essentially it says if you have the organ and there's guidelines for screening, then to go ahead and screen it.
So I know that we are very interested in anal cancer with men who have sex with men. What about women and anal cancer?
This is becoming more and more recognized of a cancer. And the reason is that the incidence of anal cancer is rising. And over 90% of anal cancers are caused by HPV. And so HPV that has, acted badly in someone else in another organ, you should consider whether they should be screened for anal cancer. We also know that 2/3 of all cases of anal cancer in women, and I think a lot of people don't know that because they associate anal cancer with men who have sex with men. But no, in actuality, there's more anal cancer in women. And some of the risk factors for anal cancer include older age, HIV, immunosuppression, and a history of that HPV causing precancer or cancer in other parts of the genital tract. So a history of cervical, vulvar, or vaginal precancer or cancer is a risk factor for developing anal cancer. And we do know from studies, a randomized controlled trial that was published last year in the New England Journal of Medicine, we know that screening and treatment of anal precancer does prevent progression to anal cancer. So there is a way to screen and prevent the cancer. We also know, based on data from the Netherlands, who they started implementing screening for anal cancer in people living with HIV in 2007 and followed them, I believe it was through 2020, and they showed that screening does decrease mortality from anal cancer. So there's more and more data coming out, and more people, patients and providers are asking about how to screen for anal cancer. And at present, the way that you would screen, the simplest way would be with a digital anal rectal exam, which is inserting a glove lubricated finger into the anal canal about 2 inches in, and then palpating 360 degrees to feel for any irregularities or lumps or areas of tenderness. And that's something that primary care clinicians can do as a screening test. And then more technical screening tests are the anal cytology, the anal pap test, and anal high-risk HPV testing, which is not FDA approved in the anal canal, but has been shown to have high sensitivity for detecting anal cancer. And so there will be some guidelines for screening for anal cancer coming out in the next few months to year by the International Anal Neoplasia Society, but they did have some preliminary recommendations that were sent to the membership earlier this year that I want to review with you, just so you have an idea of who you could consider doing the screening for until we get the published guidelines. And here you can see that we would recommend screening for anal cancer in men who have sex with men and transgender women living with HIV, starting at age 35. So anal cancer is a cancer that happens at older ages, and we don't want to start screening too young because the screening leads to a further evaluation and treatment. And we want to target it to the population that's at highest risk. For people with other risk factors like women living with HIV, we would recommend starting at age 45 and older. For men who are not MSM living with HIV, also starting at age 45. And then for people with a history of vulvar acellular cancer, starting within 1 year of diagnosis, because they're actually at very high risk of developing anal cancer. And then for immunosuppressed people, solid organ transplant, 10 years post-transplant, would be when their risk is high enough to warrant screening.
Very interesting. And so what resources do we have here at Stanford?
Well, for people who get screened for anal cancer, and I've gotten referrals from the primary care group, and they have an abnormality, then they can refer to our program, which is called PEACH, and this stands for Prevention and Education of Anogenital Cancers and HPV-associated Diseases, where we would perform the diagnostic procedure to further evaluate the abnormal anal cancer screening test. And that's called high-resolution anoscopy. We also do colposcopy of the cervix, vagina, and vulva, and treatment of precancers in any of these organs. And we're located at the Pelvic Health Center. In order to refer to us, you would have to put in a referral to Pelvic Health, and then you can enter my name for provider, and we're in Redwood City.
Very interesting. That's a great resource. Thank you so much.
And here's some references for the different guidelines that we've discussed, as well as the information to access the application to manage the abnormal screening tests.
Thank you so much. It's been so very helpful. And I guess we'll now open it up to questions.
Great. Thank you, Marcy.
Thank you.
Great. Thank you, Dr. Kahn and Dr. Levine, for that case presentations. We have a lot of questions. So there seems to be some confusion from reading through the Q&A questions, whether primary HPV testing is done by the provider with a pelvic exam, or is this self-testing? And a follow-up question to that is, would be potentially missing something in not performing the pelvic exam with self-testing?
Great question. At this time, self-sampling is not approved by the Food and Drug Administration in the US. And so the pelvic exam still needs to happen for the primary HPV testing. And so the patients would still get a pelvic exam. And when the self-sampling becomes approved, then that could become an option. And we're hoping that it will get approved because half of cervical cancer cases are in people who either don't get screened or get under-screened. And so we're hoping it'll help to reach some of the hard-to-reach populations. And but it's still an option for the patient to come in for the pelvic exam and have the testing done by a clinician.
Great, thank you. In terms of screening cessation, does it matter if the woman over 65 is dating and may have more than one partner?
Thank you for this question. We do get this question often. The natural history of cervical cancer is that it takes 20 to 30 years on average for cancer to develop after acquiring a new HPV type. And we know that having multiple partners is a risk factor for acquiring new types. So screening beyond the age of cessation of 65, assuming that they met the criteria for cessation in someone who's dating, increases the likelihood that you're going to find something abnormal. And if you do find abnormalities, then the patient could end up needing ongoing colposcopies, biopsies, etc. And so shared clinical decision-making is very important in these situations to make sure that the patient knows that they might end up in a longer-term surveillance situation if they have newly acquired HPV that we detect with the screening.
Great, thank you. If an HPV comes back negative, but the PAP is non-diagnostic, and there's no concerning history, can we just go over that HPV result and screen again in 5 years as opposed to repeating a PAP?
In this case, I'm assuming that non-diagnostic means unsatisfactory, which is usually what's on the report when there's not enough cells to make a diagnosis. In these cases, we worry that it could be a false negative potentially because there's just a lack of cellular material with a non-diagnostic cytology. And so the recommendation at this time is to repeat it sometime within the next 4 months.
Great, and a similar question, my understanding is a PAP is still satisfactory even without a transformation zone. How important is it to obtain the transformation zone in a patient who's had a history of abnormal PAPs?
Technically, you don't need to have that endocervical component to make your decision about management. And so as long as it has enough cells to give a diagnosis, then technically you can manage it according to the diagnosis.
Okay, great. And a couple of questions about anal cancer screening. What is it the same interval for screening for anal cancers as cervical cancer? Or what would be your frequency of screening?
Yeah, there's actually no guideline out right now on anal cancer screening, so we don't really know. And in my high-risk patients, I do yearly screening. So I think over the next few years or decades, we'll have more information to have more defined screening intervals for anal cancer screening. At this time, I'm doing annual.
And in terms of HPV-related cancers, like non-cervical, are there any ways to screen for example, HPV-related throat cancers? Does HPV vaccines help prevent like ENT type HPV cancers?
The American Dental Association recommends an annual oral cancer screening exam for all adults. And that at this time is the only screening test for oral HPV cancers. There's no approved type of oral PAP or anything like that in practice right now. So we do recommend annual dental exam requesting oral cancer screening. And the HPV vaccine is indicated to prevent all of the HPV related cancers, including oropharyngeal and anogenital cancers. Because it takes so long for these cancers to develop, there's not as much data on the vaccine and cancer incidences. We have some data for cervix, but for oropharynx, it's primarily indicated because we know that it's effective in the anogenital tract, and we know that the majority of oropharyngeal cancer is caused by HPV or caused by HPV-16, which is covered by the vaccine.
Thank you. Another HPV vaccine question. If someone has had the 4-valent HPV vaccine, is now over 45 and at risk, would you recommend they receive the 9-valent vaccine?
At this time, the CDC is not recommending repeating vaccination if you had the 4-valent for people at risk. You are protected against the majority of cancers. And the 9-valent added 5 different high-risk HPV types that cause about 20% of cervical cancer. So the majority of cervical cancers are caused by types 16 and 18, which were included in the 4-valent vaccine. For the other sites, 16 and 18 are really the big players. The other types are not as commonly causing cancer. So we usually do not recommend revaccinating with the 9-valent.
Thank you. And any risk for HPV in women who have sex with women who use sex toys?
Sex toys can transmit HPV. If they're going from genital to genital, then they're definitely something that can move HPV around. So definitely something to consider. And for that reason, we always recommend screening or the organ-based screening recommendations. If the person has a cervix and they haven't had screening, then they need to get their screening, and it doesn't matter what their sexual orientation is. If they're at risk, then they need to be screened.
Thank you. In a person who's had normal cervical cancer screening who newly contracts HIV, do you do every year for 3 years after diagnosis, or just every 3 years?
It depends on the test that you're doing. If you're doing cytology alone, the PAP by itself, then you're going to do that yearly for 3 years and then go to every 3 years. If you're doing a co-test, HPV plus the cytology, then you can do that every 3 years because it has a higher sensitivity and negative predictive value.
Thank you. And you mentioned that for patients with vaginal HSIL should be screened for anal cancer. What about patients with cervical LSIL or HSIL?
Patients with a history of cervical HSIL are at increased risk of anal cancer, and we're waiting for the International Anal Neoplasia Society to release guidelines. At this time, I screen those patients starting at age 45 and older who've had cervical HSIL.
Got it. Thank you. Sometimes a pap smear reports severe inflammation in an asymptomatic female with a normal pap. Is any further testing recommended? Perhaps a GC, anything else?
Yeah, that's a good question. We don't know the exact answer to that. I do sometimes offer STD testing to those patients. If they're asymptomatic, then it's a good idea to check for gonorrhea and chlamydia. If they have any symptoms, then obviously you could look for things like vaginitis. But there's no clear algorithm or pathway to follow with the severe inflammation. But and if they're asymptomatic, you can also just leave it.
Thank you. Couple more quick questions. Does Gardasil 9 cover genital warts?
It does. It includes HPV 6 and 11, which cause the majority of genital warts.
Are annual bimanual exams indicated in non-PAP or HPV screening years?
This is a good question. I think there's been question about the utility of the bimanual exam in general and whether it does truly pick up diseases. And so in my patient population, if I'm seeing them every 3 years or every 5 years, I'm not bringing them back on an annual basis just to do a bimanual. The evidence has not shown that it's indicated.
Thank you. Should we be worried about the presence of endometrial cells on Pap smear results?
The endometrial cells on PAP depends on the patient's menopausal status and also where in their cycle they are, if they're premenopausal. So you may notice that in the order for the PAP, it always asks you when was the last menstrual period. If the last menstrual period is concurrent with getting the Pap smear, then endometrial cells is expected and not worrisome. If it's off cycle from when they are menstruating, then you would be concerned about shedding endometrial cells and may investigate further. Or if they're postmenopausal with endometrial cells, then you would want to do endometrial sampling.
Thank you. In a person with a history of anal cancer who's never received an HPV vaccine is outside of the current age guidelines, would you recommend vaccinating them?
We don't have good data on people who've had anal cancer and the HPV vaccine efficacy. But in general, I lean towards vaccinating people that have had an HPV-related cancer. There is data in people who've had cervical precancer that the vaccine decreases recurrence of precancer. But we don't have good data in people who've had actual cancer from HPV. And the other thing to note with that is that anal cancer, the average age is 55 to 60. And so a lot of these patients with a history of anal cancer are outside the FDA-approved age range for HPV vaccination. And so it's really hard to get it covered by insurance.
I see. Well, thank you so much, Dr. Levine and Dr. Kahn, for your time.